Okay, well, that sounds good. And Lemian's having to drive for me because I don't know how to, my computer would not let me share my screen. So you can go ahead and go to the next slide. So just a little bit about me. So I live in Winston-Salem. Actually, this is my third stint living in Winston. Lived here as a preschooler through early elementary school and then for high school and college. And then we've been back here about 10 years. We have 4 kids who are, you'll see in my next slide.
Oh.
Is it working? Oh.
It's technology today. It's a Saturday. It's raining and my computer doesn't like me. So bear with me. I'm sorry.
That's okay. Just keep going back. We'll get there. Just don't ask me to talk backwards. There we go. So you can see my kiddos. Some of these pictures are, well, the ice skating picture on a cruise ship is kind of old. So that was my youngest daughter's Make-A-Wish trip to Alaska. So she is now 11. She's in kind of the maroon jacket on Pilot Mountain. So you can see now she's as tall as her next oldest sister. So she's 11 and her name is Madison. And then Meredith is next to her on Pilot Mountain. And then my son, Meredith is 16. Michael is my only boy and he's 18. You can see he's taller than me. And then Melanie is my oldest and she's 21 and she lives in High Point. The others are still at home. Michael's a senior in high school. So the 3 youngest all have pretty serious and very complex medical issues. They have mitochondrial disease, which has caused like a whole host of other issues. So they are on the CAPC Medicaid waiver for the state of North Carolina, and that they are the reason that I do the work that I do, both paid and for fun, I guess. I wish I didn't have to do the work, let's just say. So it's a lot of times actually not fun, but very, very needed. And it is very rewarding to see the changes that we have been able to successfully make. So my paid job is as a CAPC case manager. So as you might would imagine, that they are the reason that I got into that, being able to help get services set up for families. My kids in particular need in-home nursing care, 18-ish hours a day. You wouldn't know that necessarily by looking at them, but they're a lot of work medically, but intellectually, they are on par. My 16-year-old just had straight A's in her report card. Her lowest grade was 97. So I have to brag for a sec. Anyway, so my advocacy work, though, in 2015, the state started making changes to the CAPC waiver. And up to that point, they considered stakeholders in the Medicaid waiver as providers, providers, whether that was nursing agencies, DME companies, and case management agencies. They never considered families as stakeholders, family members. And, someone mentioned how difficult, I think it was Jessica mentioned how difficult policy is to read in Spanish. It's not a whole lot easier to read in English, honestly. There's lots of legalese and things that are difficult, even when English is your primary language, to really understand. And I really spent a lot of time digging into it and comparing the old policy to the new policy. And I had just started my work as a case manager. So I'm like, something doesn't seem right here. And why do they not consider family members stakeholders? Like, we're a very important member of the stakeholder community. So long story short, lots of work later, we got the policy back to where it was, and actually I think even better, but there is still lots of work to do, as I know Marie can attest, is requires a lot of hand holding to get through the very complicated process. So myself and two friends of mine, after about half, well, I guess really officially after that work was done, a lot over social media, we started an organization that's now our own nonprofit called Advocates for Medically Fragile Kids NC. So we continue to do advocacy, particularly at the state level, but Natalie focuses on federal. As part of that, it wasn't just the CAPC program that didn't consider families as stakeholders. The Medical Care Advisory Committee for the state that is required to have family members on there actually did not have any parents on their committee at all. And so I am the first parent that's been on that committee. I've served for a couple of years now. And we recently, with the start of Medicaid transformation, which is a term you've probably heard us talk about a lot, I'll get into that in a minute. We started a beneficiary engagement subcommittee, and so I'm co-chair of that. And then I also serve on the CAPC advisory committee. So yeah, it's pretty busy around here. You can go to the next slide. So my objectives for today is for you to walk away knowing how Medicaid works, who Medicaid serves, and then how North Carolina Medicaid is changing due to Medicaid transformation. You can go ahead. So what is Medicaid? Medicaid is a health insurance program for low-income kids, low-income adults, low-income seniors, as well as people with disabilities. So that can be children and adults. Medicaid helps millions of Americans get and stay healthy by seeing the doctor when they're sick, getting regular checkups, being able to fill their prescriptions, and being able to get hospital care without fear of choosing between their health and groceries or paying the rent. Go ahead. So, and I stole some of your slides, Lamine. Medicaid is a federal state program. So it was started in 1965 along with Medicare. You may have heard the acronym CMS, and that stands for the Centers for Medicare and Medicaid Services. So that was what came together then. States aren't required to participate, but every state has been since 1982. So the federal government provides funds towards this program as well as the state. The states run the program, but there are some federal guidelines. So that's kind of where CMS comes in. They have rules and guidelines that have to be followed. States have the ability to decide who to cover. And they also have other things that they can decide on their own, like income eligibility, what some of those benefits are, whether or not people have to pay premiums or co-pays, and sort of how that care is delivered. So there's a quote: if you've seen one Medicaid program, you've seen just one Medicaid program, because everyone is a little bit different. And if you've moved from state to state and gotten, sought Medicaid services in different states, I'm sure you have experienced that. I most certainly did when we moved back to Winston 10.5 years ago. The kids were on the Medicaid waiver in Indiana, and it does not transfer from one state to the other. It took us way too long to get services in place when we moved, which is something that I would like to see improved. But the requirements are different. When we were in Alabama, they actually didn't qualify. So it's complicated. But yes, all right, go ahead. So Medicaid makes two commitments. So to the states, for the federal matching to help pay for the cost. And then also for Americans, it's a guarantee of health insurance for covered services when medically necessary. So that's all those things we talked about: being able to go to the doctor, seek preventive care, prescriptions, hospital, all of that, without waiting lists or time limits. So if you qualify, you qualify, and you're you're able to access services right away. And that is legally enforceable. So whatever the state plan lays out is what, whatever the state plan lays out as, the state plan, then they're required to follow that. Go ahead, Lemmy. So this is a slide that's not too terribly old, actually. This was the last, I think this was presented in December at the Medical Care Advisory Committee. So this is the solid line up through where the solid line ends. That's, so like right before December, so probably through November data. Is total enrollment in Medicaid, not including family planning. So that's the actual, and then the forecast. The forecast changed obviously due to COVID. So you see the huge spike, and you can see that that's actually Medicaid enrollment was pretty level, even going back further from the data that we've seen, but there's definitely been this big spike with COVID. And they're projecting even more. So you can kind of see the cone of variability there for what they anticipate through the end of this fiscal year. And so for the state, if you weren't aware, the fiscal year is July to June, so it's not a regular calendar year. So this is something that we track on the MCAC committee, and that the state obviously tracks, as well as all of your legislators. So go ahead, Lemmy. So in terms of coverage for kids, so there's a couple of different ways that kids are covered in North Carolina. So you can see that the Medicaid bubble is the largest. So this is in North Carolina as of 2015. Yeah, it was pretty old. I couldn't find a newer chart. So keep in mind, this is 6 years old, but mostly Medicaid. And then the lighter blue is NC Health Choice for Children. So that's the Children's Health Insurance Program. So you might hear it called the CHIP program as well. I think every state has a CHIP program, but everybody calls it different, something different. So one of our goals actually is to kind of combine CHIP and Medicaid into one. It would just be way simpler with all the changes that are happening right now. So you might hear that conversation, but you can kind of see the proportion of where kids are enrolled. You can go ahead and go to the next one. So in terms of annual enrollment in Medicaid, this chart breaks it down by the different programs. So I really liked this. So you can kind of see when people talk about Medicaid really is a children's health insurance program. So you can see the TANF children at the bottom, obviously that's kids. The SCHIP, the State Children's Health Insurance Program, that's kids. The age blind disabled, that's adults and kids. So some of those numbers are going to be kids. So that's the largest portion of Medicaid enrollment. So when they aren't including the voices of children and families, we're really missing the boat here. So important for them to hear from us. So go ahead. So this is actually from the Medicaid website last night. So if you want to click on the screen, it'll take us, if you're interested in, if you're like a data nerd and you're really interested in this, if you scroll down, you'll see the dashboards. Just keep going. You'll see the map a little bit more. Keep going. There you go. So you can see the actual real-time data. Go up a little bit more, will you? There you go. So you can see real-time data of enrollment statewide, and then you can actually break it down by county. So super interesting. Like I said, if you're into the numbers and just want to see how your county compares to other counties and sort of how Medicaid enrollment is broken down, then There you go. You can do that. All right. If you can, I don't know how to get back to it. Hopefully you do. Good job. Thank you. Oops. Yeah, just don't click on it again.
I think the bottom left corner, Lemine, has little arrows. That might be a good way to move forward on slides that have links. Bottom left.
Yeah, I should have made it smaller.
It's just going to take my computer a minute. I don't want to click it a bunch of times.
Yeah, that makes sense.
Hey, Jenny, while we're waiting, can I ask a quick question? This is Marie. Sorry. What does TANF stand for, T-A-N-F, in that one graph?
Yeah, it's temporary assistance for needy families.
Okay, cool. Thanks.
And that's the food, like, it's like SNAP and food stamps
the
are all
cash
essentially
benefit.
TANF.
Assistance. Yep.
That's the cash assistance.
Okay, awesome. Thank you.
Okay, so this is just another slide, just shows where these, breaking down a little bit more what children are being covered by Medicaid. So this is from 2017, so it's a little bit newer than the older one, but, and this might, I think NC Child, do you put this out every year? Is this part of the kids data that you report on? It probably is.
Yeah, I believe there's some newer information in the child health report card that was just released. I'll forward the link to that.
Oh, was it released? I thought it was coming out on Monday. I must have
It is,
missed
well, yes, it is coming out on Monday. There was a sneak peek on.
Gotcha. Yeah, so refer to that for the newest data, but just so you can kind of see in general, 82% of kids living in or near poverty are enrolled in Medicaid. 49% of infant, toddlers, and preschoolers are enrolled in Medicaid. 49% of children with disabilities or other special health care needs are covered by Medicaid. 100% of kids in foster care, and 54% of newborns. So, yeah, I'm sure that, well, we all know that Medicaid is important. That's why we're here. So, and Medicaid isn't just about health coverage, because Medicaid helps kids succeed in life. So, kids who enrolled in Medicaid tend to miss fewer days of school due to illness or injury. They tend to do better in school, are more likely to graduate high school and attend college, grow up to be healthier as adults, can earn higher wages, and end up paying more in taxes. So,
Jenny, is this compared to kids with no health coverage, or is like generally?
believe so.
So sorry, this is Kaylin. So that was from the Georgetown Center for Children and Families. They put out state fact sheets on Medicaid every year. And I know NC Child uses that to help inform the report card data. And that's exactly what it is. It's in comparison to children that are uninsured.
Yeah.
So, yep.
Awesome. Thanks.
So this just sort of lists overall Medicaid services in North Carolina. So we've already talked about a lot of this. I know that a lot of people have talked about dental and orthodontia being important, as well as vision and hearing. Also for older adults, nursing home care. It covers personal care and other home health services, equipment, supplies, a lot of things. Everything on here, I don't need to read them all to you. All right, go ahead, Louie. So EPSDT. So I think it was Gina in our small group brought this up and she was like, I think I said that right. I'm like, I'm very impressed that, although I will say my kids hear me talk about EPSDT so much that they know what it is. That's an acronym that stands for Early Periodic Screening, Diagnostic, and Treatment. So I'll break that down for you a little bit, but basically it's a benefit for children. And for Medicaid purposes, kids are kids up to the age of their 21st birthday. So it doesn't end at 18, it ends at 21. And this is a requirement federally that they have to provide all appropriate and medically necessary services to correct or ameliorate a health condition, even if it's not something that's listed in the Medicaid state plan. So ameliorate is a fancy word that basically means maintain. So if someone has, a significant health issue and let's say someone has a feeding tube and let's say the state plan didn't want to cover a feeding tube for whatever reason. And it's not going to make the child's medical condition better necessarily, but it might keep it from getting worse. So kind of keeps things stable, then it would be required to be covered. And obviously a feeding tube is covered, but just trying to think of an example off the top of my head. So I know that I had to learn what ameliorate was, so I always like to try to let people know. But ameliorate is actually a word that it has power when you use it correctly, and especially in writing letters of medical necessity. So it might be something to hold on to for future reference in case you need that for your kids. If you can go to the next slide, let me. So early and periodic screening covers medical screens. So, your annual physical, immunizations, any lab work, health education, going over history of health and developmental milestones. It includes other screenings like vision, and then also has to cover eyeglasses if a problem arises, hearing, and dental as well. And then the diagnosis and treatment, as you probably would imagine, if the screening exam indicates that there's more testing needed or treatment that's required, then that's something that has to be covered for physical and for mental illnesses. So that is even in more recent terms as genetic testing, for example, has become more widely used. That may be something that a doctor says is necessary for, further specific diagnosis and then being able to determine treatment. So I think genetic testing is now covered under North Carolina Medicaid, but more in not too recent times, it was not. And so EPSDT was what was used to get things covered. It's still used a lot of times for specialized equipment. Yeah, super important. And like I said, that's something that is required by CMS for the states to provide. So how do states deliver care? So states have the option of doing fee-for-service, where the state contracts directly with providers and pays them for covered services. So that's what we have right now in North Carolina Medicaid for physical health. For behavioral health, we do not, and I'll talk about that in a minute. Managed care is a second option, and so where the state contracts with managed care organizations or MCOs to oversee the delivery of care and payment of services. So that's what we're moving to in just a few short months. Premium assistance, where Medicaid and CHIP funds are used to purchase private insurance that's cost effective and comparable, or they can use a combination of these approaches. Go ahead, let me. So effective versus ineffective managed care systems. And this is super important since we're moving to this in July. So an effective managed care is going to be closely regulated by the state agency. The contracts are going to specify the detailed requirements for the MCOs. Data is accurately collected and shared with stakeholders in a timely manner. Decision-making about service approval is transparent. There's an independent ombudsman. Profits are capped for the MCO, and there's a robust provider network. And some of these terms may be new to you. So an ombudsman is more of someone that helps advocate for you and direct you to kind of where you need to go. And then a robust provider network means that there's lots of doctors and other providers to choose from. So like Rachel was saying earlier, it sounds like, quite a few health plans have a little ways to go to build up their provider network in certain areas. So that's what we mean when we talk about that, is making sure that there's lots of providers in lots of places that are easily accessible, so that you're not having to go 4 and 5 counties away to receive that care. So some ineffective managed care obviously would be sort of the opposite of that. So I don't need to read all of this for you. Go ahead, Lemmy. So right now, this is how we're going to look starting in July. So both North Carolina and the federal government are putting money into the department in order for Medicare to be administered. And so the department will give some of that money to prepaid health plans. So there's 4 commercial plans and 1 provider-led entity. And their payment is based on risk-adjusted capitation. So what that means is if, say, I was someone that was covered and I'm in a category that has, say, 1 chronic health condition, and because of my age, then the state would allocate that a certain amount of money based on those factors to the prepaid health plans to cover all of my services for that month. So it's a monthly payment that's made from the department to the health plan. And then those health plans have contracted with providers, and then they pay the provider based on contracts that they've made with them for how payments are going to be received. Up to a point, if those health plans spend less on me than they got paid, then they get to keep that money. If they spend more on me than they got paid, then they lose that money. So that's sort of how that process works. And then North Carolina will continue to have Medicaid Direct. And so that's what we call our fee for service is NC Medicaid Direct. That's a new term that just came out about a year ago. And so the department will still be contracted with providers to pay them directly for people who are still in Medicaid Direct. So go ahead, let me. So North Carolina already has managed care. There are 7 LME MCOs, which stands for Local Management Entity, Managed Care Organization, and geographically specified regions across the state. And in light of time and to reduce complication, you'll have these slides. You can click on that link and it'll take you, maybe I didn't say this part. Behavioral health services are managed by those, not physical health. But that link will take you to the provider directory if you're not familiar with that. And there's a color-coded map that says, if you're in this county, this is your LME MCO. So with Medicaid transformation, there are going to be 2 types of plans. So there'll be standard plans, which the vast majority of Medicaid enrollees will be in. And then there's tailored plans, which according to the state will be targeted to serve special populations with unique healthcare needs. And we'll get to what some of those are in a minute. So I already mentioned a lot of this. So the PHPs for Medicaid managed care. So there's 4 statewide contracts or prepaid health plans. That's AmeriHealth Caritas, Blue Cross Blue Shield, United Healthcare, and WellCare. There's 1 regional provider-led entity, which is Carolina Complete Health, which is regions 3 and 5, which is most of the southern border of the state, but more central and western. And then it was just released, I think last month, that there's going to be an Eastern Band of Cherokee Indians tribal option. And North Carolina is the first state to offer a tribal specific option to meet their unique needs. So that's pretty cool that we have that. You can go ahead. So our timeline. So officially open enrollment again begins on March 15th, as was stated earlier. Open enrollment extends through May 15th. On May 15th, when enrollment closes, so starting on May 16th, then there will be auto assignment. And so based on their claims history that they have for you or your child, they will assign people a prepaid health plan based on what their algorithm thinks is going to be the one that suits you best. Managed care officially begins on July 1st. You will have 90 days to change your prepaid health plan. So it's called the choice period. And so that ends on, if I can read it, I don't have my reading glasses on, it looks like September 29th. So that's sort of the timeline for this year. That's a lot. It's going to be a lot of moving parts. It's going to be quite hectic and lots of need for family input as to how things are going in real time. So it's one of the reasons why I enjoy being involved in the PAC, is because I can be in my own little CAPC world, which is very needed. But I feel like if I'm going to co-chair something as important to me as beneficiary engagement, I need to be hearing from lots of different voices in real time about what's going on. So I'm going to be relying on you to report back what's going well, but more importantly, what's not going well, and how it could be better. If you have proposed solutions, or even if it's just like, this is my just raising a flag to say, hey, this is just not going well. That's okay too. You don't have to have all the answers. Go ahead. I think there's one more. Yes. All right. So special populations. I told you I thought I was coming to this. So some of the populations that will have tailored plans. So children in foster care, as well as adoptive placements, are supposed to go in 1 year after managed care implementation. So keep in mind, this chart was actually from 2017. Managed care was supposed to have already happened, but the department was not fully prepared, and then COVID has delayed things. And so I was thankful for this chart because it has 1 year after instead of specific dates. So I know that there was a webinar this week that talked about foster care and moving into managed care. So they're soliciting feedback for that right now. So that is something that you want to be involved in. Certain Medicaid and health choice beneficiaries who have substance use disorder, IDD diagnosis, traumatic brain injury, anything that is currently connected with the LME MCOs for receiving services, especially if they're on the innovations waiver or on the innovations waiver waiting list. There will be a tailored plan for them. It was supposed to be 2 years after managed care, but now it's 1. So that will be, there's already lots of information out about that. And there's a specific beneficiary engagement group just for that. So if you're interested in that, I can connect you. And then you can see some of the other populations, including CAPC, are supposed to go in 4 years after managed care. We're supposed to have a specific tailored plan, but as I think Lamine probably already knows, and for Kellyanne, since she's new, she can hear from me that I do not want to see CAPC going into managed care, and I am going to fight like hell to keep that from happening. So that might be it, Lamine. Yep, that is. So I don't know if we have time for questions or not. It was a lot of information, I know, so.
I am going to ask that we hold the questions till the end. I know that that was a lot of information, and